Good afternoon. At the outset, I would like to thank all of you for making it to this course. And also, I would like to thank the organizers for giving us this hall in the prime time for this very important course. As you all know, cataract surgery is in the fast lane and everything seems to be happening right for it. With the newer devices, newer technology, we are able to tackle harder cataracts these days. We have newer devices that are used. The lens technology has really taken us to a new level where every kind of patient's need is taken care with different types of lenses. And in such milieu, we are very privileged today to have a star-studded faculty, very distinguished people whom I have seen in the last several years and their clinical results. I am really proud that they will be sharing their stuff with us today. To start with, we have none other than Dr. Anaga. She is a prolific surgeon from Bombay. Her contribution in the last several years in the field of academics, organization, and other social issues concerning ophthalmology has really made us a very special person. So she is here to share with us about how to tackle the difficult cataracts. And she is our opening batsman. Over to you, Dr. Anaga.
Thank you so much, sir. Very good morning to all of you. At the outset, I'd like to thank Haldipurkar, sir, for including me in his IC. And I'll be speaking on my current approach in tackling hard cataracts. So friends, when we approach a case of a hard cataract, the main challenging part of it is dividing the hard nucleus, because many times there could be associated zonular weakness. We need to remember that there is hardly or minimal epinuclear or cortical cushion, and there is a possibility of a long duration of surgery. So there is a high risk of complications in the form of nucleus drop, a PCR, corneal burns, corneal decompensation, and a host of ocular comorbidities. And that is why we also need to look at the endothelial count. There could be a shallow anterior chamber, pseudo exfoliation associated with it, or an inadequate pupillary dilatation. So if you want to optimize outcomes, it starts with the history. So look at the age of the patient. The older the patient, the more time the lens has been, the patient has waited for surgery, the greater could be the density of the nucleus. Any kind of previous surgery, for example, a vitrectomy, which could have compromised the zonules or caused a PCR pre-existing. You need to examine the patient in the preoperative period, grade the density of the nucleus, look for any kind of zonular weakness, a mild phacodonesis, for example. Look at the visual potential so as to give the patient a good, proper and true visual prognosis. Do a specular in these cases so as to have an idea regarding how strong the corneal endothelium is to tolerate a very hard phaco. A topical versus a peribulbar. If it's a very hard cataract, prefer to do it under peribulbar block because of the longer duration of surgery. You may choose femto, phaco or SICS depending on the access that you have or how comfortable you are in that particular patient. Optimal settings of the phaco is very important. Good fluidics, a stable chamber. You need to reduce the chatter and the turbulence. So make use of power modulation or a white star technology, whatever best you have in your phaco machine. And keep the armamentarium ready. It's better to use a trypan blue to stain the anterior capsule so as to, in case you need to put in three-piece, then the edge of the capsule is very easily delineated. I usually use a 2.8 millimeter sharp phaco tip in these cases. An old phaco tip may make things a little more difficult. Remember to use a sharp chopper depending on whether you want to do a vertical chop or horizontal chop. Choose your chopper accordingly. A dispersive OVD with sodium hyaluronate and chondroitin sulfate helps to protect the endothelium, so use it liberally. Keep an iris claw and a three-piece ready as a standby. Use a CTR and high-ris hooks also as standby if at all the pupil comes down, or you might need in case of a weak zonules, and intracameral mydriatics. Definitely counseling is important. Explain to the patient what his condition is, what are the techniques or what special consumables you might need to use, and explain to him the risks and the possible consequences. And each of the surgical steps need to be looked at in detail. So here you have a very hard, dense brown cataract. When you begin, we are staining with trypan blue. Remember to make a capsulotomy or capsulorhexis which is slightly larger, so at least 5.5 millimeters or a little more than that. Because if it's smaller, then it's more likely to be get cut by the chopper and becomes more difficult to get out the nucleus. A very gentle, minimal hydro dissection in very small squirts, because we don't want the entire fluid to go behind and cause a greater posterior or anterior push. And then you go in with the phaco and bury the tip very well, at least to 80-90%, and have a complete crack. So once you use the vertical chopper just before the anterior capsular margin, you can actually go in down, have a good grip, and then move the left instrument anti-clockwise so that you can get a complete crack. So once you have a crack on one side, you can rotate and have the complete the crack on the other side. And then each heminuclei are then divided into multiple small quadrants, and each of these parts can be easily then emulsified. Remember, you can see hardly any cortex, hardly any epinucleus. So towards the end, towards the last one or two fragments, you can reduce the bottle height, be careful, or reduce the power, and then see that your chamber is extremely stable, because if at all there is a surge, there is a PC directly and there is a very high chance of a PC rupture. Also in this patient, at this point of time, I usually change my chopper to Sinskey hook, so that suddenly if there is a surge, then you don't directly rupture the PC. This is another hard cataract, and today with very good microscopes, initially with the good glow, it might not seem very hard, but the moment you touch the cataract with your Sinskey hook, when you're rotating, you can gauge the hardness of the nucleus. So initially, if there is any free cortex or epinucleus, you can just remove it. And here now we are first making a crater. So here with the crater, you can make it at 60% depth or at least around 3 millimeters, and then hold it. The grip has to be very good. And then move the left hand chopper towards in the anti-clockwise direction. Now if the grip is not good, sometimes you can have a torque which has to be avoided, because if there is a torque, then that can cause more stress on the zonules. Sometimes you may not get a complete crack even in the periphery. So here you can see that there is only a crack in the periphery, whereas in the center you get a central disc. So that means it is not yet completely separated in the center. So here we are first removing or separating the peripheral parts, and you go back down in the center, and now you are removing the central disc or the core. So there are different ways of doing it. Depending on the case and how the case fans out, you can change and use the maneuvers to the best advantage. So in brown cataracts, because of its leathery structure and leathery fibers, you need to do a multi-level chopping. So each of these levels will break each part of the fragment and make the separation. Sometimes if you do a very vigorous lateral separation in the first part, you might tend to rupture the zonules and cause a further problem. And use viscoelastic, dispersive viscoelastic in between also liberally, so that you have a better protection of the corneal endothelium. This is another patient. So again, we are doing a large capsulorhexis, very gentle and a minimal hydrodissection, and see that the nucleus is mobile. So a gentle rotation of the nucleus, putting in viscoelastic. So you can use different maneuvers. So we showed how the direct chop is used and the stop and chop. Again, removing a first initial part of the superficial cortex, and then going in. Here we are using the stop and chop technique. So if you are using the stop and chop, you have to remember to make a very deep trench. So that should be at least around 80 to 90% rotated, and make a trench which is really deep and slightly wide. Go in, hold the edge of one of the trenches laterally, and then go deep down and try to crack it. Sometimes it may not be possible to crack in the first instance, in the first attempt. Doesn't matter, you replenish the OVD, go deeper, and then go deep down and try to break. So sometimes you might tend to hold it superficially, the two instruments, that will not allow it to break. So you have to really go deep down and then make that lateral separation so as to have two complete halves. So only once you do that and you have two complete halves, then it becomes easier. Then each of the two heminuclei can easily be separated. So femtosecond laser is one of my other favorites because you already have pre-placed chopping planes, reduces intraocular manipulations, reduces the phaco-energy, endothelial loss and the zonular stress. So this was a policeman patient actually who wanted a multifocal and topical. So this you can make small cubes softening mode in order to reduce the size of the fragments. And here the best part is that you have a pre-placed nuclear disassembly as well as 5.5 to 5.75 millimeter capsulotomy. All you need to do is go in and open up the pre-placed chopping planes. So it becomes easier, but because of the leathery fibers, you need to be very persistent and see that there is a complete crack from the periphery to the center and make multiple smaller fragments, and then each of these fragments can then easily be picked up. So the advantage here is you have reduced phaco energy, that that reduces the chance of endothelial cell loss. And again you can see that the pupil is coming down. At this point of time you can use intracameral mydriatics and replenish the viscoelastic, and then each of these fragments then slowly be rotated and picked up and emulsified. In white cataracts, the amount of nuclear disassembly with the femto is limited. Here you have a postage stamp perforation, removal of the capsulotomy flap is done, and then you can go ahead. But here there is a limited effect of the femtosecond laser. So you have to go ahead with your own phacoemulsification techniques. So hold it, make a trench, and then you can see that complete separation of the fragments are done. This is one more femtosecond laser patient, but there are different ways of going ahead. Despite the diverse recent new modalities, SICS is also a preferred technique, and it has been found that hard nuclei can have endothelial cell loss as high as 42% compared to 25% in standard phaco. Visual outcomes are much better because you can create corneal edema with phaco if it's not done right, and higher risk of complications. So this was a black cataract, so I prefer to do a SICS in this patient. So please tell me when my time is up, these last two surgeries. So I've made scleral tunnel and now making a capsulotomy, capsulorhexis, and I make small 2 to 3 nicks in the edge of the anterior capsule of the capsulorhexis, so that when you are trying to dial out the nucleus into the anterior chamber, you don't let the tear go irregular or wraparound tear, and we're removing, see, look at the black, hard, large nucleus there. And then an irrigation aspiration, you have to be very, very careful and meticulous. Once that is done, then the surgery is as good as over. So this was post-op day 1, 6x6. And this was a very interesting case, sir, a very different way of tackling it, a very hard black cataracta nigra with phacodonesis. So I thought that it was a very difficult case for phaco as well as because of the very high phacodonesis. I used a very different technique, opened up the incision, and then we are using cryo to remove this. As you can see, it's a very black cataract. But this was a, there was no vitreous loss at all. Then using pilocarpine to bring down the pupil, and then as there is no capsular support here, we are making 2 side ports and using an iris claw. This is my last video. So when you're using an iris claw, be sure to see that both the claws are open, and then go in, and from the side port you use the second instrument and then enclave it in the mid peripheral iris. Again, hold the iris claw lens very firmly, and in the other side also you can enclave it very firmly. So to conclude, a good evaluation, prior planning, precise surgical technique and patience will work in these patients. Thank you so much for your kind attention.
Thank you so much, Anaga, for in fact taking us back to our residency days by showing cryo. My two questions for you. When is the indication for a planned four quadrant for you in your practice, in your cataract management? And number two, how much are you bothered about the energy that's used? Do you always have your eye on it?
Absolutely, absolutely. I think we need to have an eye on that because the harder the cataract, we know and we have to anticipate it in the first place. And that is why I use a 2.8 because the bore is thicker. Use a sharp tip phaco tip so that it's easier to cut through the nucleus, and make use of a vertical good chopper so that the left hand also contributes. So how to decide whether you make a four quadrant or a direct chop is when you make the first trench, you can feel how hard the nucleus is even when you're rotating. So when you bury the Sinski hook onto the nucleus to rotate it, if it's too hard, then probably at that point of time itself you can decide whether you want to make a four quadrant. But the only disadvantage with four quadrant is there's too much of trenching, so there's high possibility of corneal burn. So your phaco machine has to be really good. If not, or you can ask your assistant to put in even saline on top of the incision. But if you feel that you're developing more of corneal burns or it's not actually cracking, then you go in and change your technique altogether. Otherwise, if you want to stick to one technique, even on table, sometimes you're trying to do a trench, deep trench, but it's not cracking, and you feel that doing vigorous lateral separation can actually cause the zonules to get affected, then it's better to convert to even an SICS and at least bail out and prevent a nucleus drop in these cases.
Thank you. That was a very comprehensive, all different types of the way you can do, you have shown. Thank you so much.
Thank you, sir.
And now we come to the next batsman, none other than Dr. Sandeep. In fact, Sandeep is a teacher par excellence, excellent phaco surgeon. In fact, he's the one whose waiting room is always frequented by people from literary world and Bollywood. And it's my proud privilege to present to you this guy who always aims to get hit on the bullseye in every patient of his. To you, Sandeep.
Thank you for the opportunity, Suhas. I don't know whether I'm worthy of saying what the topic says, but I'll try to give my 100% as far as this talk is concerned. Good afternoon to all of you and welcome to this show. I know it's lunchtime and I am thankful to you for attending. Now, we all know that cataract surgeries are becoming increasingly refractive procedures. In fact, cataract surgery is the most often discussed surgery on breakfast table. This has been proven that this surgery is something which everybody is aware of. And patients are also aware that their friends or neighbors got operated and now they don't need to wear glasses anymore. So these patients, when they come to us, they are already aware that this is possible. And many of them require it for their professional needs. Also, many of these so-called young retired people still want to be active in life. They are not retired from life and they want to pursue so many activities which require them not to wear glasses. So there's no way you or anyone in this audience can escape this problem. Now, first of all, when you plan for these surgeries, you should be able to know whether your patient is capable of a 6/6. So a careful slit lamp examination of the cornea to see whether it is transparent enough, or are there any scars from previous infections or a previous keratorefractive procedure. Look at the anterior chamber and iris to look for signs of inflammation. Look at the lens itself, whether there is pseudo-exfoliation, is it a posterior polar cataract, is the lens decentered or subluxated. Look at the pupil for its size, look at for its centrality and for its circular shape. Look at the tear film. Remember, the light bends at the air-tear interface and 75% of the refraction happens there. So if you've got to give 6/6, your tear film has to be good. Look at the lids, look for signs of meibomian gland dysfunction. Look at the cornea, see whether the patient is aqueous deficient. Do tests to verify for tear volume and tear film stability. So you need to do a T-butt and a Schirmer's in almost every case. Look at the fundus. Very often behind the dense cataract there are pathologies which can be easily missed out. And now coming to the most important thing, corneal topography. If today you are planning to make your patient emetropic, no ophthalmic surgeon can overlook a corneal topographer. Now there are so many uses of the corneal topographer, but with respect to cataract surgery, There are 5 things that I'd like all of you to remember. 1, see whether your cornea is prolate or oblate. Look at the astigmatism. Is it regular, irregular? Is it symmetrical, asymmetrical? Look at the higher order aberrations on the Zernicke polynomials. In particularly, look at the spherical aberration and the vertical coma. And look at the pupillometry. Many of the topographers have a dynamic pupillometry, so are able to get the size of the mesopic and scotopic pupil. Now, in this Zernicke polynomials, I don't want to go in details and explain mathematics, but 2 things you need to look for. The Z40 spherical aberration, which as far as possible should not be greater than 0.4, at the most 0.5, especially when you're doing presbyopia correcting IOLs. And the Z3 minus 1 of the vertical coma, this should never be more than 0.35, especially if you're planning some such special IOL. Now I want to illustrate this with 2 simple examples. Now this is a cornea which is highly prolate, as you can see. And if you look at the Zernicke polynomial, his spherical aberration is 0.38, which is a very, very good value for a presbyopia correcting IOL. On the other hand, look at this lady. She has got asymmetrical astigmatism, but note the cornea, flatter in the center, steeper in the periphery. This is definitely an oblate cornea. Look at the Zernicke values. Z40 is 1.179, almost as if she has had a LASIK procedure, which is not. And her coma is 0.9. Now this is not a patient who is an ideal candidate for that. I now perform an OCT in almost all my cataract patients. You never know when you might have a patient with an epiretinal membrane and you are promising him a multifocal lens. You need to be on your guard. Very often the patient's intraocular pressure is very normal, 15, but yet the OCT may show signs of a reduced RNFL thickness. There may be a subtle diabetic macular edema. There may be a small macular hole due to vitreomacular traction, not to mention the large pigment epithelial detachments and the AMD, which very often these patients are associated with. Do the specular microscopy in all the cases. As Anaka rightly said, you need to know how soon is your patient going to recover from the surgery. Now coming to the IOL power itself, the most important thing is precise data acquisition and appropriate IOL power formula selection. In data acquisition, formerly we used to only collect the actual length and the keratometry, and we used to put in the SRK, SRK2 and the SRKT formulas. But if you want to be more precise, if you want to develop or give emetropia, you need to measure the anterior chamber depth from the epithelium to the anterior lens surface. You need to look at the lens thickness and the white to white diameter. Sometimes hypermature cataracts come and an optical biometer cannot be used, in which case we need to use an ultrasound. Now don't accept the value whatever your optometrist gives you. Look at the scan values again. As you can see, the first scan on the left, it's not the proper retinal spike. The one on the second and third are, but look at the second again. Because of the hypermature cataract, there is an echo within the lens itself, and the lens thickness is shown as 1.444. Here you need to adjust the marker and push it to the posterior capsule. Probably the scan on the right is the best scan that you should take. And I think every single surgeon has to see the USG, especially when it is done on those cases where an optical biometer is not possible. When placing the instrument, the patient on the optical biometer, go from behind, see whether the head is tilted. Look whether the patient's head is naturally tilted when they come to you. Look at whether the patient is looking straight ahead. Otherwise, you will get a picture like you get on the right side. And make sure that the lateral canthus is aligned with the positioning mark on the instrument. When you get the scan, look at the Myers. The Myers should be sharp. The fovea should show the natural dip as you should. If you get a value like this, now see, the limbus has not been recognized. See the picture on the right. You'll find you'll get a wrong WTW value, and that is going to affect your IOL power, my dear friends. Sometimes subtle macular pathologies like a macular edema or a cyst may be picked up on the optical biometer itself without having to do a OCT. Now there are special axial length considerations. Optical biometry can provide the entire longitudinal scan of the eye, so it can diagnose lens tilt, macular pathologies, etc. Optical biometer is far superior to ultrasound, and ultrasound is superior as compared to immersion, and immersion is better than ultrasound. And the swept source OCT based axial lengths are far superior to the PCI or the OLCR based biometers. And optical readings as obtained on the axial length readings as obtained on the optical biometers are longer than what are measured by the ultrasound, where it measures from the cornea to the internal limiting membrane, and this one goes right up to the RPE. Now, several kind of instruments are available for your keratometry value, and if you have them, take your measurements on as much as you can. If you find that there is too much variation, you can use the Barrett calculator to integrate these values. Now, few considerations regarding the keratometry. Optical keratometry is always better as compared to manual and auto because these go closer to the central zone. There's not much difference between the OCLR and the swept source because all of them are within the 2.5 zone. Dynamic keratometry in the Varion goes to even the central 1.2, but it is of doubtful superior value as it does not get integrated into the various IOL formulae. And TK, as measured on the IOL Master 700, no financial interest there, is more useful in post-refractive surgery and post-PK eyes. As far as the anterior chamber depth and lens thickness and white to white are concerned, they enhance your value, especially when you're using non-regression and some of the later 4th and 5th generation values. They give you a more accurate effective lens position. And optical biometers also provide you the coordinates of the visual axis, so they help you to measure the angle alpha. Now, choosing data for calculation. If it's an optical biometer, you take the keratometry, you take the action length, all the readings, and do the calculation on the same machine. But that mature cataract comes where you have taken the action length on the ultrasound. Now be careful, don't use the optical biometric K value because the A constant is designed with optical readings only. So if you're going to use in a hard cataract, you're going to use the immersion, then probably take the K readings on the either on the auto K or on the manual. Choice of formula. My go-to formula in most cases are some of the regression formulas like what are available on the Barrett suite, and that is my first choice. But if I find my patient's eye is very long or very short, then I don't hesitate to look at also the values on the Haigis and the Holiday 2. And especially in those cases where there has been a refractive surgery in the first eye, it is useful to use some of the artificial intelligence-based formulas like the Hill RBF and the LEDA super formula. Be careful in recognizing and accepting the K values when the patient has had keratofractive surgery or has keratoconus. In eyes that are very long, greater than 25.2 millimeters, you need to use the Van Gogh modification of the axial length, and this is given over here on the slide. But if you're using the Holiday 2 or if you're using the Barrett suite, then you don't need to make this adjustment at all. Astigmatism, you cannot do cataract surgery overlooking either the pre-existing astigmatism or the astigmatism that you are going to create. So you need to look at your own SI depending on your incision size and the location of your incision. Maximize the usefulness of the astigmatism by planning your incision and using your own SI. Now, if your incision is going to be less than or equal to 2.4 and you're going to sit temporal, then you can safely use a centroid value of 0.1. This is just a guidance, but it's always better to do your own this. Now, these are the two formulas which I go to. The one on the bottom, the Barrett toric calculator, is what I use in all cases because very often you think the astigmatism is nothing and you may be surprised that the Barrett toric calculator shows that a T2 model may be required. Personalization of your A constant is always a must. The manufacturer's guide is only an indication. You need to do at least 25 cases and put them either on the Warren Hill website or if you have your Varion, put it in your own machine and get your own A constant right. Now, when it comes to surgery and if you are going to do an eye where you are promising emetropia, please don't use an old knife. Use a disposable knife. It hardly costs anything nowadays. And you will be able to get the best possible wound construction. Good wound construction means good healing. Good healing means less SI. You should judiciously use your viscoelastic, as Anaka showed so beautifully. If you are going to use do a hard cataract, then you need to use a good OVD. This is the time when you will put the dispersive against the endothelium and put a cohesive like Helon at the bottom on the pupil. Or you can go to the ultimate soft shell where you can keep the little bit of BSS on the anterior capsule followed by the cohesive and the dispersive. This helps to do an easier rexus. Always the CCC should be as regular as possible. During surgery, remove all the viscoelastic within the bag. Always sit the IOL in the bag. Tap it in so it's there. And always align the optical center of the IOL with the visual axis of the bag. When closing the eye, make sure that you have inflated the eye enough. If you do not inflate the eye and you keep it under pressure is low, watch for that posterior corneal gape, which happens. In fact, it closes only at around 40 millimeters of mercury, and then you need to burp again to make sure that your wound is closed well. And the effect of that is for you to see. This is day 1 post-op, and you can see the incisions have healed and sealed so beautifully with no edema around the wound. So the roadmap to success, it's a careful diagnostic evaluation, excellent biometry and a proper IOL selection, meticulous incision planning and neutralization of your astigmatism. You should do a safe and efficient phaco and accurately place the lens in the bag, tap it in and align it with the visual axis. Thank you so much, because see, every happy patient contributes exponentially to your practice. Remember that, and good luck to you. Thank you.
Thank you so much, Sandeep. That's a beautiful talk which has covered practically all the points. I have a question for you. When it comes to toric placement, now we all know that if you focus on, getting your eyeball firm at the end of the surgery, there's always a chance that there'll be some fluid under the lens and the lens might shift a bit. So when it comes to putting a toric, what are the special precautions you take to make sure the place where you kept your toric is going to stay there?
So when it comes to a toric lens, as you very rightly said, it is absolutely mandatory that you put it bang on the visual axis. The first thing that you have to do is to remove all the viscoelastic under the IOL. From both side ports I go in and aspirate whatever little visco or fluid is there. Then as I inflate the anterior chamber and I hyperinflate it, you can see whether the IOL is moving. Most of the time, if you're using a hydrophobic acrylic lens and with a slim haptics, which are having a broad area of contact, the lens rarely moves. In fact, if you keep the pressure low, there is a chance that fluid will go in and may rotate the lens. So except in that given situation, very unlikely that a very large capsular bag, I like to keep the eye a little pressurized. In fact, I would like to keep it around 25 millimeters of mercury, at least, so that the lens will sit where it is. And post-operatively, one little thing which I would like to share with all of you is that each and every single toric that I do, as soon as I come out, I take the patient, before the next patient goes in, I see the patient on the slit lamp, because there is nothing like slit lamp to tell you the accurate alignment. Whatever digital markers you use, whatever marking lines you use, there can still be an error. But put the patient on the slit lamp, if the shift is more than 5 degrees for T4 and above, I will take the patient inside and rotate the lens. If it is more than 10 degrees for T2 and T3, I'll again take it inside.
Thank you. Thank you, Sandeep. And now we come to the next speaker. I'm very pleased to introduce Dr. Tanvi Haldipurkar. I have seen her blossom into a fine phaco surgeon in the last 10 years. And today she's going to touch on a very important topic. In fact, it's a time when in the world, the EDOF lens is sitting to practically replace monofocal as the default lens. Now when you have this and every player comes into the market with their own EDOF, it's time we understood what this EDOF concept is and what is it that we should be looking for in EDOF. Here to you, Dr. Tanvi.
Thank you. Good afternoon, everyone. To begin with, I have no financial interest in any of the lenses I'll be mentioning today. I want to discuss few updates that we've looked at the EDOF lenses in the past, but I think that begs the question that what really is the definition of an EDOF? What is it? So the American National Standards Institute has defined an EDOF to have a depth of focus which should be 0.5 diopters more than what a monofocal lens gives. It also says that the distance corrected intermediate vision should be 20 by 30 or better in at least 50% of eyes. So it needs to be superior to a monofocal. The corrected distance visual acuity should not be less than a monofocal. And they have not mentioned any criteria for any photic phenomenon. Now we know that EDOF lenses have become a part of the presbyopia correcting armamentarium today because the transition of the distance as well as the intermediate vision is fairly good and most patients are happy without any dysphotopsia. So rather than having multiple foci like how we see in a multifocal lens, what we see with these EDOF, or what we actually need today, is to have a smooth, non-interrupted plane of focus. Now, although the concept of EDOF has been in the market for the last 8-9 years, they've not really picked up, and that's because I think they've been marketed wrongly initially at least. For example, when Symphony came, it told us that it's going to give us vision very well at all distances, and it should lack photic phenomenon. And what happened is that it lacked, or rather it failed in both counts. Now today when we look at Symphony, we know that it wasn't supposed to give us good near vision, but a very good distance and intermediate. So I think a better understanding of the EDOF concept, the optics, will help us choose and counsel the patients better. Now we have very different EDOF lenses in the market, and all of them use different principles, but these are the main 5 types that most lenses go by. So a better understanding, I think I want to classify the EDOF lenses as a pure EDOF lens, which uses properties of spherical aberration, chromatic aberration, pinhole effect, and the wavefront shaping. And then we have the hybrid EDOF lenses, which will use optics of diffractive, refractive rings to use or add another focus with a low near power, and therefore give us a good intermediate vision. I'll be discussing all these principles in brief so we can understand them better. Now, spherical aberrations already exist in the eye, and I think it was probably nature's way of prolonging presbyopia. But there was a time when we wanted to neutralize them to get crisp distance vision. Now, we've understood how to use this spherical aberration to do our bidding and to give us a better depth of focus. But there is a limit to what we can increase and how much can we increase. A lot of studies have been done, and they have shown that if we increase the spherical aberration of more than 0.6 microns, we can have rather if we increase it more than 0.6, we would have less than 0.6, we would have a decent depth of focus without causing much blur. So therefore, armed with this knowledge, several companies are now trying to use this spherical aberration. How it actually works is very interesting, and I would like to show you how. So we know this is the Zernike's pyramid. This is just for us to understand why the Z has those 2 numbers. The M denotes the number of the affected meridian, and the letter N denotes the number of slopes along the meridian. Now a wavefront is flat. If it is flat, there are no aberrations. If the wavefront is affected in 2 meridians and with 2 slopes, it is called astigmatism. If it is affected in 1 meridian but has 3 slopes, it is called a coma, and this goes on so forth. When we look at spherical aberrations, which is what Dr. Vikar sir has made it easier for me to understand, is that the number of slopes that are present will lead to the type of spherical aberration that is there, and as the slopes keep increasing, it becomes more and more complex, but it gives us a larger depth of focus. Now let's see how. So if the marginal ray is the same going through the same plane as the peripheral ray, it's going to give you 0 spherical aberration. The wavefront is going to be flat. But if the central or the marginal rays are flatter than the peripheral rays, it's going to increase the depth of focus. So this kind of modulation this is the primary spherical aberration that most lenses are employing now. Now over here, what is interesting is the first lens that I'll be discussing, which is the Rayner lens. Now this principle is used by that, where they use this additive effect of a positive spherical aberration along with the naturally existing corneal spherical aberration. So this will give us a good depth of focus and giving you a decent intermediate vision. Now scientists wanted to further stretch this optical property of the spherical aberration and see if the depth of focus can be elongated. Now this was primary spherical Z4 aberration, and when you increased another slope to it, so therefore you got a Z6, what you found that the depth of focus increased. Now you could increase these slopes either positively or negatively, and what they looked at and saw that this was larger when both the curves were positive. So an optical bend study which was conducted by Bernard et al., they found that although it made sense that both positives increased the depth of focus largely, the combination of a Z4, Z6 in the opposite directions gave the largest depth of focus. Now this principle is used by the mini well lens, which has a positive and a negative Z4 spherical aberration in alternating rings, and that's what gives you the depth of focus and good intermediate vision, while the Lux Smart lenses uses the Z4 and Z6 spherical aberration. Now although all these depth of focus in these lenses are larger, what we found is that the combination of using these higher order aberration gives you a little loss in contrast, And in case of a smaller pupil, it may really not work well. So a good selection is required. Now, some lenses use a pinhole principle where it reduced the parallel visual rays, thereby eliminating the refractive error and even the aberrations. But the drawback here is that it caused those visual field restrictions. But I think it may have a role in certain patients of post-RK where it could in fact improve the visual quality. But this principle of EDOFs is not really so popular anymore. Then came the lenses which made changes in the central geometry and the optics of the lens. So some changed the power from the center to the periphery, some had asymmetric power distributions, and some lenses also manipulated the wavefront by adding some kind of segment, all of which ultimately leading to a good intermediate and distance. So here you can see the optical principles of all the different lenses. Some of them are stretching the wavefront, which has a delayed and an advanced wavefront, like for example in a Vivity lens. In the ICRL cert, you have different segments. They are kind of like refractive rings which help you again stretch the depth of focus. And then the magnificent, which there is an increase from the center to the periphery, which is also similar in an eye-hands lens. Then came the hybrid multifocal EDOF lenses. These are lenses which have either a refractive or a diffractive rings, and in fact they are multifocals with just a low near rad. So they give very similar defocus curves like an EDOF lens, but they will have photic phenomenons like glare halos, like how you'd expect in a multifocal. And these are the lenses which have both refractive and diffractive elements to enhance the depth of focus. So with so many IOLs to choose, it is a good idea to look at things a little bit more systematically. So this is the IOL algorithm we follow in our practice. When the cataract has been looked at primarily by an optometrist, before he is dilated or put any drops, he undergoes a biometry. The biometry will give you a basic assessment of what the corneal astigmatism is, but we go ahead and do a corneal tomography because we get a lot of data from this machine. First, it will tell me if the corneal cylinder is matching with the optical biometry. It will tell me whether it is regular, whether it has any uneven or irregular steepenings present. It gives me a clue about the posterior corneal astigmatism as well. The next very important measure, that is the pupil size, we can get even from another machine, but this could give you an understanding of which lens would you deviate towards while you use for that patient. An assessment of the angle kappa as well as angle alpha is given by the tomographer. And again, when we do the calculation, depending on what the astigmatism is, as how sir had explained, we then go with the Barrett calculator and plan it. What we also get from these tomographers, and something we shouldn't ignore nowadays, is to look at the higher order aberrations. We know that most premium lenses or any lens which may have rings in it will not work very well if the higher order aberrations are higher than 0.3. So you need to look at that. But today with the lenses, and most of these lenses utilizing or manipulating the spherical aberrations, you should also look at the corneal spherical aberration profile. And this could help you understand that if you use a lens which just enhances the pre-existing corneal spherical aberration, you may do very well with a basic lens or a lens which you may not even consider if you won't look at the corneas. After all of this, we finally then dilate and do the clinical examination. So to kind of summarize with these few pointers, I want to say that if you have a cornea with spherical aberration pre-existing of around 0.2 or 0.3, a lens like a Ray 1 or a Mini-Well will work well. If the pupils are too small, I would suggest avoiding any of these spherical aberration modifying lenses. You could even avoid Vivity considering it has that smaller segment right in the center. And for patients who drive, you might want to avoid the hybrid EDOFs because it's going to give them those photic phenomenons in the night. And patient, if he's okay with a small near rad, most of our EDOFs today work very well. If you counsel them well, and or if you even combine them with a slight monovision, you're going to give them a very good, decent, practical visual acuity. So I would say EDOF lenses today are suitable for all ages. They give very good quality of vision with very minimal loss of contrast sensitivity. You need to look for these patients. If somebody is a poor reader, if they are having less inclusion, or rather they're not a very finicky person about their daily routines, they have active lifestyles and want good vision for distance and intermediate, then EDOF is the way to go. Well, of course, this doesn't say that we cannot do or we can do away with the trifocals, because somebody who is very hell-bent on not using glasses for reading and still wants very crisp near vision, trifocals are the lens for that. So I would say no one size fits all. At the end, EDOF is an excellent solution for presbyopia correction, and today it is a no-brainer to use an EDOF instead of a monofocal in every patient. But it will replace it, or it will replace a trifocal, or it will give a complete spectacle independence, depends on the expectation and the lifestyle of the patient, and that's where the chair time matters. So for example, a housewife who is a poor reader and will practically be spectacle free post an extended depth of focus lens, but a jeweler who may want to see things up close and still doesn't want to wear glasses will require a trifocal. So at the end, a proper counseling or using the monovision with a EDOF, I would say that the lenses are definitely here to stay and grow. Thank you very much.
Thank you, Tanvi. That was a very comprehensive talk. Finally, uh, how sensitive are you to to macula which is not absolutely healthy when it comes to choosing EDOF?
So there are another subset of lenses which are called the advanced monofocal lenses today. So if the macula is not very good, I would want to stay away from the hybrid EDOFs completely. But the EDOFs which are not using the spherical aberrations but have sort of a maybe I will choose the category which has the lens which goes from the center to periphery where there's a uniform increase. That is the lens I would probably choose. But then going for a monovision with a monofocal lens would be the best solution in a compromised macula.
Thank you so much. Now we go to the next player. Oh yeah, please.
Hello, ma'am.
Hi.
Ma'am, as you told that we have to investigate before choosing a proper EDOF lens, but in your practice, what is the maximum percentage of lens you are putting?
EDOF lenses, you mean?
Because like we don't have corneal topography or tomography.
Yeah.
So what is the most apt lens for Indian population?
So clinically, to be very honest, we are now almost shifted 80 to 90% for patients, unless it's a financial reason for them not to go for a monofocal, we do implant an EDOF lens. So I would stay away from any of the spherical aberrating modulating lenses because you don't have a tomographer, you don't really know how will it show clinically post surgery. Lenses like the iHands, the Magnificent, the Vivity, I think, of course, the pupil needs to be looked at for vivity, but the Magnificent lens works very well in almost every type of subset of patient. That's the lens we are using.
But ma'am,
and working well.
Magnificent and hence they themselves, they call that they are advanced monofocal. They say don't call us EDOF.
So again, like I said, the definition is still not really solid and or put in paper. But what you need to understand is what do you get post surgery? You are wanting to give the patient a good distance, a good intermediate at around 50 to 60 centimeters distance, and the patient, if you combine it with monovision, will have a decent N8 for near. So if you understand what the patient wants post surgery, you need not classify it even as an advanced monofocal or a EDOF. It's what the lens gives you. And this clinically, so we've compared 3 lenses that we did a study recently where we looked at iHands, Magnificent as well as Vivity. And all 3 lenses, although few differences are there of course, all 3 lenses gave very good intermediate visual acuity. So a 0.3 logmar visual acuity at intermediate was seen in all these 3 lenses. So as long as you understand what the lens will give the patient, it doesn't matter what you define it as, but these 3 lenses work well.
So how about when we explain it to the patient that advanced monofocal, there is jumping of vision, there is no continuous range of vision and there is no depth of
A
vision.
monofocal lens will never give
Advanced monofocal.
Which lens do you mean in particular?
iHands and Magnificent.
There is no jump in vision. You will not just have a good near visual acuity because there are no different foci, right? It's a extended depth that they are getting. It's an extended focal length. So there will never be a jump.
So no difference between Ray 1 EMV or Magnificent, like it's all
There is a
same.
big difference in the way the
That's what-
optics are.
Can I just come in?
Yes, sir.
It's very simple. You said, what will you tell your patients?
Yes.
I mean, I have a very simple way of putting it. I tell him, if I put a monofocal, you will need to wear glasses always. You will have a reading aid of 2.5. If I put a trifocal, you can practically do away with the glasses because you can do your reading well without glasses. But with EDOF, your reading aid would definitely come down to 1.5. Now, if you go by that classification of EDOF, all these lenses more than classify into EDOF category, because all these lenses, if you look at that defocus curve, it is convincingly broadened. Okay, some do better. When they do better, like let's say Vivity, when it does better, that means their chances of giving you a reading aid of 1 or sometimes in 0.75 is much more than for others. But unlike monofocal, all these EDOFs will definitely bring down your reading aid to around 1.5. Okay. Second thing, when you say in a setup where there are nothing and you still want to use, if you are convinced clinically that a patient has a healthy eye, his vision has good chances of improving, and you obviously don't see clinically anything wrong with the macula, EDOF is a better bet than going for a trifocal. Okay, because remember, EDOF would be a default lens, like how aspherics became the default lens compared to spherical lenses. Okay. Okay. Now, thank you so much, Tanvi. Wonderful talk. And I invite my very old good friend, a scientist, Dr. R.C. Shah. He is a very prolific surgeon. He has a practice in Bombay. In fact, he is one of those who has the courage to call his clinic 6x4 clinic. So that means he delivers that. And there are a lot of innovative ideas that come into his mind, and he and his friend, they always come out with such additions into ophthalmic instruments and drugs. Over to you, Dr. R.C.
Thank you, Dr. Haldipurkar, for giving me the opportunity to speak on this dais. Evolving lens technology and my approach. Evolving lens technology today is trying to rectify the previous mistakes which we have done because of the lens design deficits. Now, what are the deficits which you have seen? I have done about 19,000 multifocal lenses so far. I started in 1989 with IOLab bifocal lenses, diffractive all multifocal lenses, gone and visited most of the factories except one, and I have learned a lot of things, how they manufacture, how the designing is done. So today I am sharing my experience of 19,000 and almost 30 years of experience. Now, what were the deficits which were there in the past? First, I will discuss in monofocal the edges of the anterior and the posterior surface. The glistening material which we all aware of it, in spite of that we are all using it because of the financial gains. Aspheric and spherical aberration IOL first was introduced by Technics platform of 0.27. I visited and met and stayed with him for a day. Tom is the scientist who did this thing, and he explained the things, and from there my journey to understand the IOL technology started about in 1995, and the 6 mm optics which were there in the, these are the errors of the past. Now we have most of the lenses which are of anterior square edge. The most important which we got is the posterior surface, which is a double aspheric, double square edge, which is known as an enamel double square edge. It was introduced probably by Rayner for the first time. Here you see in this picture, you can see that two edges are there next to each other. So it has got a double barrier of posterior capsule opacification. Coming to the material of the IOL, which has taken a progress in the science. First is hydrophobic, hydrophilic, all of us know about it. The next one which is expected to come in next 5 years is the fluid optics. The fluid material which will be delivering us the accommodative IOL. Surface modified which was there in the past, heparin coated, which has worked very well with uveitic patients. And now most of the manufacturers are shifted to hybrid material. So it behaves like an hydrophilic when you deliver the lens in the eye, but it behaves like an hydrophobic as far as the PCO is concerned. These are the few accommodative fluid IOLs which are expected to hit the market in next 5 years. They are all in the investigation in the United States. It has got a double optics, you can see here, and these optics moves in front and back whenever there is an accommodation which will change the blue portion of the lens. Second one is here, which is known as the Omni View, which will be again in the process of investigations. If I'm not wrong, this particular lens has gotten US FDA approval recently, in which whenever there is an accommodation, this fluid comes in the center and changes the power of the lens. And the last one which is there is jealousy, where the lens moves with the accommodation, the contraction and relaxation of the ciliary body with the change in shape of the capsular bag. Then came the large optics. We were the first one with Dr. Kakadia in our company. I have a financial interest in that, where we created a 7.5 millimeter large lens to negate the negative dysphotopsia. The lens name is Autofocus Pro, which is a varifocal IOL. Rayner is the other company which has got a collar strut technology, where you keep those two collars on the temporal part. This will also help you to avoid the negative dysphotopsia. This is already Tanvi has told you about the various spherical aberration lenses. Now we come to what are the deficit which was there in the multifocal lenses. All of us now moving away from the ring refractive IOL. It might be something which is little strange, but in next 5 years, the ring IOLs will disappear. It will go to number of varifocal lenses which are expected to hit the market. Recently, one IOL company got approval from USA, which we expect to hit by December in our country. Moving towards uniform distribution of power of light from center to the periphery. Here we always have some part is distributed, elongated focus. They are all very good, but over a period of time, this will ultimately disappear. And our is the only lens which has got a uniform power distributions in all 360 degree from center to the periphery. Moving towards truly pupil independent. This is something which is going to be little difficult even for us. Moving away from micro and monovision, because most of the patients wants to see clear for all the things. Moving towards photopsia free IOLs. Probably this might be a distant dream at present. Then we need to have a continuous vision. I have given you the one paper which will help you to find out your own way any multifocal lenses to find out the depth of focus, and that is a true way of finding out the performance of the IOL. And this is what we want. This is what we want. It might be little difficult today with the present technology, but this is what we see in varifocal IOLs, whether it is Autofocus Pro. There is another lens which is available is Lentis. It is coming from Germany, and there is one more lens which is expected to come from USA. I don't know the name, but we have spoken to them, and probably this type of depth of focus you need to do. The whole idea is then you can see in plus up to 1.5 also the patient vision does not change. That shows that even if there is a refractive error of 0.75, without putting a glasses, the patient still sees 6 by 6. And the other side, which is on the minus side, you will see almost the same uniform. Even if it is a -3 correction, the patient can see. That means they have a very good depth of focus for distance, and we assume that the same thing is also there for near. So with all this understanding with my friend Dr. Kakadia, we have designed the lens which is known as autofocus spray, and that is what my present approach for multifocal lenses. Can you start the video? It is with the voice.
Hello dear friends and colleagues.
Can you start the voice?
Happy to introduce to you Autofocus Pro, a unique and novel ringless polyfocal progressive IOL.
Can you start the voice?
Hello dear friends and colleagues. Today we are very happy to introduce to you Autofocus Pro, a unique and novel ringless polyfocal progressive IOL which gives excellent vision at all distances, far, near and intermediate, without haze, halos and starburst, which is completely free from negative dysphotopsia. Autofocus Pro looks almost like a monofocal but works like a multifocal. It is an aspheric polyfocal progressive lens without any diffractive rings. It is static and fixed in the bag. There is no mechanical pseudo accommodation, but yet it functions like an autofocus lens and hence the name. Progressiveness of this IOL is visible on 9-deck OPD scan, which is much similar to varifocal lenses. This OPD scan nicely illustrates the wonderful progressiveness of this IOL with distance dominance in central area of photopic pupil. This is the sketch of design and dimensions. This is the schematic optic of autofocus progressive polyfocal optic, which gives excellent DIN vision, that is distance intermediate and near, by green technology, that is gradient refractive index. As you can notice, there is no loss of light energy because there are no diffractive rings, so there are no photons which are lost. This is the schematic optic, and as you can notice that even with different sizes of pupil, the ratio of the distribution of light remains the same. These two dialing holes are also position indicators to be kept in upper half of eye. They also help to drain out any remaining retroiol viscoelastic. Undulated haptics are inspired from postal stamps border. Haptics are completely atraumatic, just like knuckles of our fist. Resistive but atraumatic haptics can be mentally compared to the surface of custard apples. Large and horizontally oval optic covers full visual field, hence there is no negative dysphotopsia. And 6 mm long L-shaped zigzag edged haptics provide rock solid rotational stability. Lifeline Millioptics Autofocus Pro is available as both options, as hydrophilic and as preloaded hydrophobic. This silky, smooth and soft IOLs injection is very easy, as good as any other soft foldable IOL. And as you can notice, unfolding is gentle and slow. And once both haptics are in the bag, we have to rotate the IOL so as to keep both dialing holes in upper half of eye, keeping the IOL horizontal as best as possible. At any size of pupil, light distribution proportion remains the same, hence it is pupil independent. There is no light energy loss because there is no destructive interference or diffraction, and angle kappa or angle alpha are of no significance nor of importance. In this retroillumination, we can barely perceive the different zones of Autofocus Pro IOL. This is the only ringless progressive IOL having all zones in central 0.9 mm area, and hence it is independent of any pupil size. This is the typical post-op fogging over refraction chart, and as we can see that from +2 to -4, the vision remains almost the same, which is almost like 6 diopters of amplitude of pseudo accommodation. This is the typical DOF chart of autofocus.
Because of the shortage of time, Autofocus Pro and the Lentis are the two lenses which will give the best depth of focus today, and they are practically free from the dysphotopsia. So the conclusion is moving towards the IOL with minimum or negative, no dysphotopsia, moving towards the continuous vision IOL. Very good depth of focus is necessary for satisfied patients of all the professions. Spectacle independence for almost all distance, and the minimum PCO, and no or near no contrast loss. Thank you so much.
Thank you, Ramesh. And with this, we now welcome the star legend of ophthalmology. He's the doyen who has taught phacoemulsification. He pioneered it way back in the early 90s, and he has taught it not only to so many of us in India, but all over the world. A very simple and humble human being, but his achievements are really legendary. So please take the stage, sir. It's all yours.
Thank you so much. Good afternoon. Thank you so much for staying on. My talk is going to be a little different from all these previous excellent and wonderful talks. I just want to shift the gear and take you lower down. I just want to come to it with simple ways to optimize cataract surgery. See, all of us know and believe that cataract surgery is our bread and butter, and sometimes it is true, literally and spiritually. So now in this talk, I'm going to look a little bit spiritually. All of us are into meditation. All of us believe in, mindful living. So for an ophthalmologist, mindful living is a part that you do when you are in the theater, and that's the right time to do. And that's the reason I'm going to take you through some of the steps. If you believe that by being in that state during your cataract surgery, one, your surgery can become better. Number two, it can really make you feel, live longer and more happily. It's a very simple case, nothing hi-fi I'm going to show you here. You remember in the first speaker spoke about hard cataracts, very hard Brunnesen cataracts. No, those are the cases where if you can shift a little back, instead of being in the cornea, you come on the limbus, you come on the sclera, it makes a huge difference. Now this is a case of post-RK. Obviously in a post-RK you hardly have any space. Luckily in this you have, but still if you stay little posterior, one thing, these post-RK patients who are normally high myopes, there's always a distortion in the cornea when you're operating. And suppose this patient has, let's say, a cornea which is not very healthy, what happens is, by staying little posterior, your phaco tip is all the time away from the endothelium, and it's a great thing for endothelial protection as well. Now in this today's markerless era, there are times when if the pupil is extremely large or if the AC is too shallow or too deep, to get exact size of the rhexis is difficult, and to get exact size rhexis is definitely important. One, because you want to have a symmetrical overlap on the lens at the end of the surgery, and these are simple devices which definitely help you get a perfect kind of a central circular opening. And when you put your lens inside, when you see that perfect overlap, it goes a long way in stabilizing your post-op results. Now, sometimes when there's a long-standing, post-traumatic lens colobomortis eyes, and if you have an access to some of these devices which are there today, because these are all fibrotic capsules, you can use this. Like here, I'm using Zeptorexis marker, but you also have, another new devices of this kind. And one thing about this patient is, in these long-standing colobomas, traumatic colobomas, the rest of the zonules are strong enough. So it is possible to manage the nucleus even without the help of the hook. But at the end of it, you would definitely use an endocapsular ring, because you want to have a 360-degree circular circumferential kind of stretch on it. And then these traumatic mydriasis patients, the pupil doesn't come down, so there certainly pupilloplasty, which is popular with Dr. Amar, comes handy. And I think every ophthalmologist must learn this simple trick of doing pupilloplasty, because it has several indications. Now this is a patient, 5-year-old girl. She came with a microcornea for cataract surgery, and obviously because the pupil was very small on the table, femtorexis could not be done. And in this case or otherwise, when you have a subluxated cataracts, and if you want to stain the capsule, like in this case I wanted to stain the capsule, because when you stain, the consistency of the capsule changes, and it's always for your good. It makes your rhexis easier. But if you stain the eye, there are chances that your stain can go posteriorly and your visibility gets disturbed. So the trick here is make a small opening in the anterior capsule and just inject your stain inside the capsular bag. So the stain doesn't come out, it doesn't go posterior. You just wash it, then fill the eye with viscoelastic. So what happens is your visibility is preserved, and then you can go with the forceps and complete the rhexis. And in such cases, as you know, at some stage when you don't get a proper counter pressure, you have to use hooks to get that counter pressure before completing it. And while doing all this, the staining certainly helps you, do your job simpler. Well, the ophthalmology cataract surgeons are divided into two, either they are bimanual or coaxial. I am a strong coaxial and I have reasons for that. Now this is a case without any editing. When you use coaxial, the amount of fluid that goes into the eye is almost double of what your bimanual can give, and it's so quick. Your AC is all the time much deeper than when you do it with the bimanual, and you can literally do all the angles with comfort. And that's the reason, that was one different take on coaxial that I wanted to share with you. This, of course, I have shown in the past. Today, with incidence of floppy iris going up, people on tamsulosin are more. Even ladies are taking tamsulosin. And when you have this, very often at the end of the surgery, this is a pesky problem because the iris tends to come out. So there's a very simple solution for that. What you can do is just go through with a spatula through the side port, just press on the iris back and do whatever you wish to do, and the iris just doesn't bother you. So this simple thing that can definitely help you. Now, I was asking Sandeep about the placement. This is one simple step I have been doing for a long time. If you just notice it again, at the end of the surgery, when you are done with your case, while irrigation is on in the AC, go with the spatula and press the lens back. It literally goes back and you suddenly see your AC deepening, and it stays that way. It's definitely good. Very often in such post-uveitic eyes, when the iris is plastered on your lens capsule, the best way of separation is to do visco dissection. Find a small gap and fill viscoelastic. Try to fill it all around so you have a much better separation of the iris from the lens capsule. Then of course it is very important that you create that circular pupil, because it is not enough to see well, you also want to look good, and to have a nice circular pupil for a patient is definitely something that patient would want. For want of time, I would rush through. Now, very often when you have cases like this and you want to enlarge it, obviously you are going to use one of those pupil expanders, but the pupil is so small and you don't want to really stretch it hard because you don't want to tear it. But it's possible with the pupillary expanders that we have. You have to stretch it, be very gentle with it. With little patience, you can certainly open it up, and then of course you will end up with a fibrous capsule. Even here, by staining it and using your Rexis forceps, you can certainly do it. And this is my last case. This patient came 8 years before with firecracker injury and laceration, and he was operated and there was a lot of tissue loss, and 8 years later he comes now with cataract formation. Now in this case, at the end of the surgery, he needs a toric lens. When I put the toric lens, the placement is such that even after keeping it in the proper axis, it is not centered. So obviously, the next thing that I will have to do is to fix the lens. And there are different ways to fix it. I prefer to fix it with an ASIA anchor. And this ASIA anchor is a beautiful paper clip like a device which you have to hold with a micro forceps from the opposite end and fix it in. And then obviously there is so much of a iris defect. First assess if you can bring that iris in the center into that place, and once you are confirmed that you can use the pupilloplasty technique and you can get it in the center, and by getting this pupil, making a circular pupil, you certainly help in cutting down on those aberrations, peripheral aberrations, and the patient at the end of 2 weeks was improving to 6/9, which was definitely a big thing for that patient and for me also. So in summary, every step starting from incision to wound closure can contribute to make surgery safe and efficient. Compassionate approach to tissue respect goes a long way to make cataract surgery a pleasurable experience. Thank you so much. Since we have the next session coming up and we are already crossed our time, we would like to say thank you to all our delegates who are present here. Thank you so much.